Good afternoon, everyone. So I'll be presenting a free paper on neurofibromatosis of eyelid and orbit, presentation and surgical management of mechanical ptosis. So there are no financial interests or conflicts of interest. Neurofibromas are common benign peripheral nerve sheath tumors, often appearing as soft skin-colored papules or small subcutaneous nodules. They are composed of Schwann cells, fibroblasts, perineural cells, mast cells in a myxoid influence background. There are three main types of neurofibromas. The localized ones are the most common, followed by diffuse and plexiform type. NF1 is an autosomal dominant disorder and is caused due to mutations of NF1 gene and affects approximately 1 in 3,000 persons. So these are characterized by various features which include cafe-au-lait spots, axillary or inguinal freckling, iris cleach nodules, optic nerve gliomas, and sphenoid dysplasia. The plexiform type is the pathognomonic one for NF1 and it carries an increased risk of malignant transformation. The diagnosis of NF1 is crucial for all clinicians due to its varied presentation, including vision and life-threatening malignancies. So this study aimed at understanding these varied manifestations of NF1 for making an early diagnosis and treating it wherever necessary. So the aims and objectives of this study were to study patients with NF1 with ocular involvement of lid and adnexa and to evaluate the outcome of surgical management for excision of lid mass causing mechanical ptosis. So it was a retrospective case series. All patients' records that satisfied the criteria of neurofibromatosis according to the NIH were included. Exclusion criteria included all those patients with atypical neurofibromatosis, NF2, or any other genetic disorder related to lid and orbital lesions. So 7 patients with NF type 1 were studied for manifestations in eye and orbit, causing visual impairment due to ptosis or amblyopia in this study. Patients diagnosed with NF1 underwent general physical examination, ocular examination, which included a detailed history, visual acuity test, slit lamp, fundus examination, and MRI scan, if done, confirmed the presence or absence of intraorbital and intracranial masses. So the NF1 diagnostic criteria requires at least 2 of the following 7 criteria. We should have at least 6 or more cafe-au-lait macules, more than 5 mm in greatest diameter. Axillary freckling should be there, Lisch nodules, 2 or more neurofibromas, at least 1 plexiform neurofibroma, or a first degree relative with NF1. So in our study, we had 4 families, of which we can see that 3 families had patients or the affected individuals involving 2 consecutive generations. Except for family 3, the rest of the ones were involved. Coming to family 1 now. So it was a 14-year-old male diagnosed with NF1. He came with complaints of drooping of right upper eyelid and multiple swellings throughout his body. He had delayed milestones. There was a history of second-degree consanguineous marriage. Similar complaints were seen in the father. Autosomal dominant pattern of inheritance was there. So here we can see the pictures. That was the patient at 1 year of age. And at 14 years, we can see the right eye, the severe mechanical ptosis, and the lid mass. So multiple hyperpigmented macules were seen over the face, trunk, and upper and lower extremities, suggestive of cafe-au-lait spots. Bilateral axillary freckling was there. Then yellowish brown raised nodules involving the iris, suggestive of Lisch nodules was there. And S-shaped deformity with a classical bag of worm sensation causing the eyelid to droop was there, suggestive of severe mechanical ptosis. Coming to the radiological findings, X-ray skull AP view showed the bare orbit sign, and there was also this swelling in the zygomatic area. CT brain, soft tissue thickening in the right periorbital and zygomatic region was noted. A bony defect was also seen in the right greater wing of sphenoid, suggestive of sphenoid dysplasia. Coming to MRI brain, small hyperintense foci in the left frontal white matter and left globus pallidus was noted. However, there was no evidence of optic nerve glioma. Debulking of the neurofibroma of the right upper eyelid was done, and mechanical ptosis correction was achieved using frontalis sling surgery with Ethibond suture 5-0. Surgical excision of the lesion present on the zygomatico-temporal region on the right side of the face was also done. So these were the pre-op and the post-op day 1 images. Histopathological evaluation confirmed the diagnosis of neurofibroma. Coming to family 2. So it was a 7-year-old male with NF1 with congenital pseudoarthrosis and acute osteomyelitis. So he came to us with swelling on the right lower limb since childhood. It was a non-consanguineous marriage. History of NF1 was there in the family as seen in the pedigree chart, and there was pseudoarthrosis. So here we can see the images on my right hand side, the pseudoarthrosis of the right tibia, the bowing of the legs, and the remaining features are also there. So coming to family 3 now, it was a 20-year-old male diagnosed with NF1. He came with dimness of vision in left eye and lesions on skin over the upper back. It was again a consanguineous marriage. On fundus examination, we found a macular nevus and an optic nerve pit. So now coming to family 4, it was a 5-year-old male diagnosed with NF1. It was again a non-consanguineous marriage. History of NF1 in the father. And these are all the images, the cafe au lait, axillary reflecting leash nodules, and involving the son and the father. Now results, 3 families had involvement with multiple cafe au lait spots, axillary freckling, leash nodules over iris, and nodular lesions of autosomal dominant distribution. One patient with severe mechanical ptosis due to the lid mass had poor lid elevation and underwent excision of the lid mass and sling procedure using Ethibond 5 sutures, the Fox pentagon method, resulting in significant improvement in eyelid height and function. So this is the pictorial depiction of all the various clinical manifestations. Cafe au lait leash nodules were seen in all the patients, axillary freckling in 50% individuals, one patient with plexiform neurofibroma, mechanical ptosis. Coming to the consanguinity, 50%, that is 2 families had consanguineous marriage, and 2 families, there was history of non-consanguineous marriage. So discussion, all the cases in our study met with 3 or more criteria which aligns with the Gunjan et al. Study. A single case of eyelid neurofibroma causing mechanical ptosis was reported in our study, similar to again Neha K et al. Study. And Boring K et al. Found that multiple leash nodules are a specific indicator of NF1, which was also confirmed in our study as 100% of the patients had leash nodules. So long-term evaluation of NF1 patients with significant lid or orbital masses needs to be done to avoid complications and keeping in view the possibility of a malignant transformation. Ethibond sutures can be effectively used in children for correction of congenital ptosis or mechanical ptosis with good results in comparison to silicone rods. So these are my references. Thank you.
Thank you very much. What was the follow-up of the patient you did surgery? Debulking.
The follow-up was good, ma'am. There was improvement in the lid height, and the patient is doing well now.
Long-term follow-up means recurrence, etc.
No, ma'am. No recurrences.
How long did you follow?
2 visits. Then we lost to follow.
2 visits means how months? 6 months?
Like
1 year?
2 months and then 4 months.
Okay.
Hello. Okay, so when you were exploring during surgery, what type did you find? Is it plexiform? Was it easy to dissect?
It was quite superficial. It was not it was dissection could be carried out.
So which is the most difficult one to dissect?
The plexiform.
Because it goes along the
yes,
nose, so that will decide whether it will come back or not.
Yes, ma'am. True. Thank you.
Okay, next, Dr. Ramya. It's not there. Dr. Smriti.
A very good afternoon to all the respected judges. I'll be presenting a case series on orbital exentration. Orbital exentration is a radical and disfiguring surgery involving removal of the entire orbital contents, including part of the optic nerve as well as the lacrimal gland. Some pathologies also warrant the removal of orbital walls. They may be lid sparing or lid sacrificing. Based on the structures which are conserved, they are classified as subtotal, total, or radical. Basically, in subtotal exentration, we retain eyelids and part of the conjunctiva. In total exentration, the eyelids are also resected, and in radical exentration, orbital cavity bones are also resected. The video on the right side of the screen shows, the video is not playing. Okay, the video on the right side of the screen shows a lid sparing orbital exentration done in a case of invasive OSSM, and the video on the, sorry, is it playing? Please pause the timer. In and out. Okay. Ma'am, should I continue or should I start again?
Continue from here only.
Okay, ma'am. So the video on the left side of the screen shows a lid sparing orbital exentration done in a case of invasive OSSN in our center, and the video on the right side of the screen shows a lid involving orbital exentration done in a case of right or rhabdomyosarcoma of the right globe. Okay, coming to my first case, this was a 35-year-old female patient who presented with progressive painful proptosis and diminution of vision. Patient underwent orbitotomy and excision biopsy 6 months ago elsewhere, and she was diagnosed as hemangiopericytoma there and started on chemo and radio, but she was lost on follow-up. On presentation at our center, PL was absent in the right eye with proptosis and features suggestive of panophthalmitis. Upon imaging, there was a soft tissue dense mass in both intraconal and extraconal compartments of the right globe. Of the right orbit. The lesion involved the lateral rectus muscle, and there was a bony erosion in the floor of the right orbit and extension into maxillary sinus. All features suggestive of malignancy. The patient underwent a radical orbital exentration under general anesthesia, and the socket was left to granulate. The biopsy report showed grade 2 clear cell rhabdomyosarcoma, and the patient underwent radiotherapy for the same, but she reported with recurrence over the wound surface after 2 months. Coming to my second case, an 86-year-old male patient presented with right eye diminution of vision and foreign body sensation. Upon examination, a mass of size 3 into 2 into 1 centimeter was found over the temporal bulbar conjunctiva, which bled on touch, associated with total corneal opacity and an absent PL. Extraocular muscle movements were restricted in the right eye in all the lateral quadrants. NCCT orbit showed an ill-defined lesion in the lateral, involving the lateral rectus and lacrimal gland, abutting the surface of the globe. There was no intracranial extension. After a lid sparing subtotal orbital exentration, the biopsy report showed a well-differentiated grade 1 invasive squamous cell carcinoma. The patient showed no signs of recurrence or surgical site infection after 6 months of follow-up. The patient is currently on regular follow-up and doing fine. Coming to my third case, this was a 48-year-old male patient admitted to the COVID ICU of our center in June 2021. He was treated with high-dose injectable steroids. He had no previous history of diabetes mellitus. He gradually developed blackish discoloration around the right eye with periorbital edema. We provisionally diagnosed him as mucormycosis, and the MRI showed involvement of the orbital apex and the ethmoid sinus. DNE with orbital exentration was done, socket reconstruction with titanium grid, and a rotated forehead flap was given. Microbiological study revealed fungal hyphae, and histopathology confirmed it to be mucormycosis. Recurrence occurred in spite of local and systemic amphotericin B, and the mass was excised again. Luckily, he survives and comes for intermittent checkups. In case 1, the patient underwent a radical orbital exentration including removal of periosteum, yet she reported with recurrence due to extremely invasive nature of sarcoma, whereas in the second case, a lid sparing orbital exentration was done as the pathology was limited to ocular surface. Most common indications are malignancies and necrotizing infections. In 2 out of the 3 cases discussed here, socket reconstruction could not be done due to high risk of recurrence of malignancy. A study by Ko et al. Concluded that although it is an aggressive procedure, it is not unreasonable in well-selected patients. So our take-home message is that the type of orbital exentration can be customized as per the patient need based on the location of pathology. As a destructive procedure, the aim should be to attain margin clearance so as to avoid further morbidity to the patient. Patient should be rehabilitated with socket reconstruction in cases where possible, and outcomes can be extremely favorable in well-selected patients. Thank you.
What was the final cosmetic rehabilitation you did in one case
In the first case, ma'am, actually she presented with recurrence, and even there were liver mets as well. So we just gave a occluder over the left eye, over the right eye. We couldn't do much in that case because already she had liver mets and she was undergoing radiotherapy and chemotherapy both. So locally for the exenterated, the anophthalmic socket, we couldn't do much really. Thank you.
Next, I call upon Dr. Kavita.
Is Dr. Kavita here?
Dr. Ramya?
That's all. Yeah. Okay.
Dr. Kavita is not there. Dr. Nimisha?
my my topic is post-traumatic exophthalmos caused by a carotid cavernous fistula, a case report. I have no financial interest to declare. So basically, carotid cavernous fistula, they are abnormal communications between the carotid artery and the cavernous sinus which provoke a pathological arteriovenous shunt. They are rare but a lethal complication after trauma. According to Barrow's classification, they can be type A, which are direct connection between the IC and the cavernous sinus, and they are usually high flow and seen after a severe head injury or rupture of any cavernous aneurysm. They are mainly treated by endovascular approach. Type B, C, and D, they are indirect and usually low flow. They are mostly idiopathic and resolve spontaneously. My case was a 55-year-old male resident of UP, a mechanic by profession, who presented with the chief complaint of outward protrusion of right eye, limitation of eye movements, and diminution of vision since the last 14 days. He was apparently well 20 days back when he suffered a motorbike accident, which was followed by swelling and redness of the right eye. There was history of loss of consciousness after trauma, as stated by his attendant. There was no history of any ENT bleed, seizure, or vomiting. He noticed gradually progressive protrusion of the right eye 6 days after trauma, which was associated with limitation of eye movements and gradually progressive diminution of vision. There was a history of increase in protrusion of eyeball on bending forward or after cuffing. No history of any tremor, weight loss, sweating, or palpitation. No history of waxing and waning course. No nasal bleed. No history of swelling in any other part of the body. No history of recent URTI or any known comorbidities. No history of any prior surgery or any addictions. General physical examination was performed, which was within normal limits. Then on ocular examination, the patient denied perception of light in the right eye, whereas in the left eye it was 6/6, and there was no acceptance in the right eye. Then in the left eye, color vision by Sciarra chart was within normal limits. Contrast sensitivity was also within normal limits. Facial asymmetry was present. The extraocular movements in the right eye were limited to -4 in all the directions of gaze, whereas they were full and free in the left eye. IOP measurement could not be done in the right eye due to a tense lid edema. In the left eye, it was taken by GAT. It was 12.2 millimeter of mercury. On examination of the left eye, the lid's conjunctiva were within normal limit. There was a clear cornea, anterior chamber depth was normal, pupil had normal sensation and normal reaction, lens was clear, and fundus examination was also within normal limits. In the right eye, on inspection, Nafziger sign was positive. There was outward protrusion of the right eye. Fullness was seen at the superior and inferior aspect of the orbit. There was a hemorrhagic chemosis, which was evident after lifting the upper lid. A tense lid edema was there. There is bluish blackish discoloration of the skin over the eyelids. Dilated vessels were present on the overlying skin, and increase in proptosis on bending forwards. On palpation on the right eye, there was local rise of temperature over the eyelids. Tenderness was present. Fingers could not be insinuated in the supraorbital and the infraorbital space. Examination by Hertels revealed a 6 mm proptosis of the right eye. Pulsations were felt over the lids, which were synchronous with the heartbeat. There were no palpable lymph nodes, and on auscultation, bruit was heard. Then the investigations, the blood investigations revealed no abnormality. Chest X-ray was also normal. NCCT head was done as a part of trauma procedure. There was an extradural hemorrhage along the right parietal lobe. The right parietal bone, lateral wall of right orbit, and anterior wall of right maxillary sinus fracture was seen. There were bulky extraocular muscles on the right side, along with fat stranding in the extra and intracoronal fat space. A DSA was done, which revealed a direct CCF from the internal carotid artery draining into the superior ophthalmic vein. These are the images. First one shows an MRI revealing the carotid cavernous fistula. Next image, it depicts the contrast CT, which was done, which revealed a dilated superior ophthalmic vein. And the third is the CT angiography scan, which shows the carotid cavernous fistula. Then this is the pre-op photograph of the patient, and on the left-hand side, we can see the post-op photograph of the patient, which shows a decrease in the edema after the post-embolization was done. So this case was decided to be treated by endovascular approach, and after coiling, complete obliteration of the carotid cavernous fistula was achieved. This coiling was done by the neurosurgery department. A 55-year-old male presented with chief complaints of outward protrusion of right eye with limitation of extraocular movements to -4 and gradually progressive diminution of vision since 14 days. Examination revealed a tender lid edema with dilated tortuous vessels, hemorrhagic chemosis, and pulsating exophthalmos right eye, synchronous with the heartbeat, 6 mm proptosis, increase in swelling on bending down, and Bruy heard on auscultation. So cerebral angiography is the gold standard for diagnosing this. And the goal of endovascular embolization was basically achieving thrombosis of the fistula while preserving the patency of the ICA. And diagnosis and management, it is not a simple process as it requires concerted efforts by the neuroradiology, maxillofacial department, as well as an ophthalmologist. And so this requires a high index of suspicion to establish diagnosis and prevent serious consequences to improve the prognosis of the patient. These are the references. Thank you.
You could not take IOP in this case, but did you feel it digitally? Did you try?
Digitally, it seemed high, ma'am, but exact measurement could not be done.
So what is the cause of raised IOP in such cases?
Raised IOP could be due to increase in the episcleral venous pressure, which is basically because there is shunting from arterial to the venous circulation, which causes increase in the back pressure. So the episcleral venous pressure increases.
Thank you. Yeah.
Thank you, ma'am.
Okay, one more question. What is your role in this?
So, ma'am,
The
basically,
procedure is done by interventional radiologist,
Yes, ma'am.
neuro-interventional radiologist.
So the patient first presented to an ophthalmologist with the proptosis of the eye. So it could have, if it may have not been diagnosed at the right time. There could be a delay in doing
Correct.
the.
Plus, if you have to intervene, what are the ways that you can intervene in some cases?
Ma'am, like in early cases, we can give a pressure
First
lowering.
thing, as ma'am said, you have to measure the IOP and
Pressure lowering agents have to give in the
Yeah.
early period.
Is there any role of conservative management in one of the Barrow's grades? Which grade?
Ma'am, the indirect ones.
So
they
what
are
can you do? Sometimes it works.
So in those cases, the IOP measurement has to be done.
No, have you heard of carotid compression?
Carotid?
Compression.
Yes. Like
Will it help?
manual. In this case, it will not help because it is a high flow fistula. In the indirect ones where there is low flow, it can help.
You know how does it act? How it acts? Carotid compression.
Exact, I don't know.
Okay, I think some of them have come. I think we should leave them. Okay. Can I call upon Dr. Shweta Verma now? Shweta?
So good afternoon everyone. I'm going to present a case of 73-year-old female resident of Delhi who came with the chief complaint of diminution of vision in left eye since 1 year. And the patient was apparently well 1 year back and she was apparently asymptomatic when she complained of sudden blurring of vision since 1 week when she presented in the OPD, which was insidious in onset and it was painless. Then there was no history of any redness, watering, photophobia, colored halos, glare, headache, broache, steroid use, night sweat, fever, sudden weight loss, cough, ocular surgery, trauma, or any other pigmented lesion anywhere else in the body. In past history, it was not significant. There was no history of any diabetes, hypertension, TB, asthma, any cardiovascular disease or renal disease or any other chronic illness. There was no history of any systemic illness. Then personal history, family history were non-significant. General physical examination and systemic examination of the patient were within normal limits. Then in local examination, visual acuity in right eye was 6/9, unaided, and in left eye it was perception of light with inaccurate projection of rays. Digital tension was normal in both eyes. IOP with non-contact tonometry was 15 in right eye and 16 in left eye. Extraocular movements were full and free in all the cardinal position of gaze in both the eyes. Lid and adnexa were normal in both the eyes. Conjunctiva was normal in right eye, while there were prominent episcleral vessels seen near the nasal limbus in left eye. Right eye sclera was within normal limit, while the left eye sclera showed 2 into 2 mm region of scleral thinning, which was present near the caruncular region, as you can see in this figure. Then the cornea was clear in right eye, while there was fine endothelial dusting in the left eye. Then iris had normal color and pattern and no nevi in the right eye, while in the left eye hyperpigmented spots, that is iris nevi, was visible. In anterior segment in right eye, it was of normal depth when Herrick grading 3 with no reaction, while in left eye it was irregular in depth, ranging from Van Herrick grade 1 nasally to grade 3 in the center with no anterior chamber reaction. Pupils were normal in size and reaction in right eye, while the reaction in left eye was sluggish, both direct and consensual reflex. Then lens was clear in right eye, while it was nuclear sclerosis grade 2 in the left eye. Anterior vitreous was clear in right eye, while in left eye, anterior vitreous mass with neovessels and hemorrhage were visible on the surface of posterior capsule of the lens, touching the posterior capsule of lens. Then on fundus examination with distant direct ophthalmoscopy, glow was present in right eye in all the quadrants, while in left eye it was only present in the temporal quadrant. On direct ophthalmoscopy, disc was normal in size, shape, color and margin in the right eye. NRR was healthy, foveal reflex was present, while in left eye, the glow was present only in the temporal quadrant, media was hazy and rest details could not be assessed. On indirect ophthalmoscopy in right eye, background and blood vessels were within normal limit, while in the left eye, the media was hazy due to vitreous hemorrhage. Huge mass was seen in the vitreous cavity arising from nasal retina extending up till the anterior vitreous. Neovessels and hemorrhage touching the posterior capsule of the lens could be appreciated, and rest details were not clear. Then this is the picture of right eye, which was normal. This is the dilated pupil image of right eye, and similarly the left eye. Here you can see that there is visible neovascularization on the posterior surface of the lens, and there is nuclear sclerosis grade 2. On USG-B scan, there was no proper A scan overlay for this patient. Evidence of large echogenic intraluminal polypoidal soft tissue lesion of size 18.6 into 13 mm was seen in the vitreous chamber of the left eye with internal vascularity. However, no obvious extension was seen into the surrounding soft tissue along the optic nerve, and the surrounding orbital fat appeared normal. Then this is the MRI brain and orbit with contrast. Here you can see a well-defined, mildly enhancing T1 and T2 hypointense polypoidal lesion of size 13 into 14 into 15 mm, which was seen in posterior chamber of left eye. Anteromedially, the lesion was extending up to the lens, abutting the posteromedial margin and its medial attachment, causing the anterior bulge of medial ciliary muscle. Then also vitreous hemorrhage was appreciated with maximum thickness of 7.7 mm, and right ocular globe was normal. Then whole body PET scan was carried out for this patient, where FDG, avid enhancing polypoidal soft tissue density lesion of size 1.6 into 1.4 centimeter with maximum volume of 22.24 was seen in the posterior chamber of left eye, and no cervical lymph nodes were appreciated. Then investigations were carried out for this patient, and in view of scleral involvement, enucleation was carried out under local anesthesia and sample was sent for histopathology. This is the image of the sample, the enucleated eye, and this is post-op 1 day image with confirmer, and this is a post 1 month image with prosthetic eye implantation. Then on histopathology, tumor size was 1.8 centimeter. Tumor growth was, it was a solid mass. On histological type was 90%, greater than 90% were epithelial cells. So this is grade 3 uveal melanoma. Scleral involvement was present, and ocular structures involved were choroid and vitreous. Tumor location was between the choroid and ciliary body, and the TNM staging was P, T3, NX, MX. In view of scleral involvement and ciliary body involvement, and impression was left eye malignant melanoma. So the case summary is 73-year-old female presented with complaint of gradual onset painless and progressive diminution of vision left eye for past 1 year, and then visual acuity was 6/9 in right eye, and in left eye it was PL positive PR inaccurate. Enucleation was carried out for this patient, and histopathological examination revealed the lesion to be malignant melanoma. These are the differential diagnoses for my case: malignant melanoma, choroidal hemangioma, choroidal mets, and choroidal nevus. Thank you.
Was there any nevi in the right eye?
No, ma'am. There were no nevi, no hyperpigmented spots in the iris.
So the picture, clinical picture.
हाँ जी, ma'am.
The first viewer.
Okay.
Right eye. I thought there is
Inferiorly,
inferiorly. This one.
Is that a nevus or
No,
just a
ma'am.
shadow?
It's just the shadow, ma'am.
Why the shadow will be so localized as if it's only confined to the iris? Can you explain it?
Ma'am,
Yeah.
Okay, how was the IOP in that affected?
ma'am, IOP was absolutely normal. It was 16 by NCT, and digital tension was also fine.
So, is the neovascularization seen as a part of your?
Yes,
is there a
ma'am.
chance of patient developing a neovascular glaucoma, or you want to?
Ma'am, there was neovascularization on the surface of the tumor, and since it was touching on the surface posterior capsule of the lens, so neovascularization was visible on the posterior
Okay,
surface.
when you did the B scan, you saw a large mass, right? What is that one investigations you want to do before going to PET scan? That you want to rule out the mets in which organ and which blood investigation you want to do?
Ma'am, ultrasound whole abdomen can be done.
What is the most common site to
Liver.
get mets?
Liver, ma'am.
So you should do liver function and liver.
Yes, ma'am. MRI of liver and.
So is Dr. Ruju is there here? Yeah.
Good afternoon, everyone. Myself, Ruju Nadkat. I'll be speaking on a series on dermolipoma, decoding the dermolipoma. Dermolipoma is the most common epibulbar choristoma and second most common conjunctival tumor in children. Although it has very characteristic clinical features, it often gets confused with orbital fat prolapse. So, this study was designed with a purpose of decoding the dermolipoma in terms of its demography, clinical presentation, ocular associations, systemic associations, management, and outcome. So, it was a retrospective interventional consecutive case series including 32 patients over a duration of 20 years. Most of the patients presented to us in first decade with age range starting from as early as 5 months to 58 years and median age being 16 years. Male is to female ratio was 2:1. Most common location was superotemporal, which was seen in 53% of cases, temporal in 38% of cases, and superior fornix in 3% of cases. Cilia was seen in 11, that is 34% of the cases. Other ocular associations included lacrimal gland prolapse, which was seen in 19% of cases. Lid coloboma was seen in 2 cases, which is 6%. Most common systemic association was Goldenhar syndrome, which was seen in 3 cases, 9%. In all the cases, auricular appendage was present. On radiology, a well-defined iso-intense heterogeneous extracorneal soft tissue mass was seen, which was not continuous with the retrobulbar fat. Management options were surgical excision versus conservative management in form of observation, which was followed in 56% of the cases. For surgical excision, here I am highlighting the key surgical steps. Conjunctival incision was made at the site of maximum conjunctival adherence to the tumor in view to preserve maximum conjunctiva. Dissection was carried out in a plane between conjunctiva and tenons. Excision was done at the site of truncation. Surface reconstruction was done with AMG and glue. Histopathology revealed typical features of choristoma, including mesenchymal elements and fat globules. These are the 3-month post-op outcome of the patients with excellent cosmetic and functional outcomes. No, there was 0% complication rate, 0% recurrence rate, and good cosmesis in almost all cases. So here we could derive a very good management protocol, when to operate and when to observe. So we operate all the cases with symptomatic, all the symptomatic cases with hair shaft or cilia, and for the patients who have cosmetic indications, and all the asymptomatic cases can be observed. Dermolipoma and orbital fat prolapse are close mimics but can be differentiated with these key points. Dermolipoma is a choristomatous tumor, so it is observed since birth, whereas orbital fat prolapse is due to weakening of Tenon's capsule, hence present in elderly. Dermolipoma can be seen unilateral with a pale pink whitish form immobile mass and straight or concave anterior border, whereas fat prolapse is usually bilateral intense pink yellowish soft mobile and with a convex anterior border. Fat prolapse increases in size with pressure over globe. Dermolipoma is typically seen in subconjunctival plane, whereas fat prolapse seen in subtenon plane. This point is very important actually in terms of managing it surgically. These are the very few handful literature available which actually invites for a further scope of research for this entity. So to conclude, dermolipoma is purely a clinical diagnosis, has distinct clinical features from orbital fat prolapse, present as a part of oculo-auriculovertebral spectrum, thus making systemic examination mandatory in all the cases. Careful surgical excision in pre-tenon's plane followed by surface reconstruction can give gratifying outcomes. Thank you.
So how many patients in your series had associated syndromes?
9 cases, ma'am.
And in that, what was the age group?
Age group was usually 9 years for systemic associations, because the patients who had systemic association tend to have came early.
So in your series, what is the eldest? I mean, who was the oldest patient?
62.
So what one investigation you want to do to confirm it's not any other this thing?
It is mainly a clinical diagnosis,
correct.
but in case of a doubt,
better to confirm.
We can do MRI. So in case of orbital fat prolapse, the lesion is continuous with a retroorbital fat plane, whereas in other cases like dermolipoma, it is not continuous with the retroorbital fat plane.
Before you go in for surgery, especially in that age group, better to confirm.
Yeah.
Right? Can you?
62 you said the highest.
Yeah.
So why did he come at the age of 62? Why didn't he? If it's not a fat prolapse, he has lived his whole life. So was there any symptom and why did he turn up?
He didn't have actually any symptoms, just because he was retired and then he just thought of seeking an opinion. He came for a usual ophthalmic examination and someone pointed out that, okay, you have a mass, and that mass term brought us.
You do a MRI?
MRI we rarely do in a case of dermolipoma. Yeah, we did.
And you operated?
Yeah, we operated him.
Okay, can you tell me? Can you tell me why you have included one of the indication for surgery, hairs with shaft, something like that?
Yeah, because patient will be symptomatic with constant foreign body sensation, irritation in the eye. So all the patients with cilia will be symptomatic, and we tend to operate those cases.
Okay. Because some people, because they are very fine here, sometimes they don't cause any symptoms.
Yeah,
Anyways, one more thing, what precaution you take while excising this lesion?
Yeah, so what we do is we make a spindle shaped incision very close to the site of conjunctival adherence, where the mass itself is very adherent to conjunctiva. It is not totally adherent to the entire conjunctiva. So we can preserve the maximum conjunctiva and tenons.
That is one thing is to conserve the
Conjunctiva.
What is one more important?
Lateral rectus and lacrimal gland, palpebral lobe of lacrimal gland, we take extra care not to damage them. And
Just remove the anterior part. No, I don't think this.
posterior, no. So that is why I highlighted that truncation. Whenever you see that truncation, you excise from that part, and all the posterior part of the tumor goes in the retrobulbar space.
Thank you.
So, is Dr. Vanita here? Yeah.
Good afternoon, everyone. I am going to present case series on ophthalmological implications on carotid cavernous fistula. Written informed consent was obtained from patients for the publication, and there is no conflict of interest or financial support. Carotid cavernous fistula is an abnormal connection between the cavernous sinus and the carotid arterial system. Direct carotid cavernous fistulas are often caused by single traumatic rent in cavernous segment of internal carotid artery. They are usually high flow and more common in younger individuals. Dural carotid cavernous fistula may develop spontaneously in the setting of hypertension, atherosclerosis, collagen vascular disease, and they are often low flow and symptomatic in middle-aged or to elderly women. Case 1 is a 53-year-old female presented with chief complaint of diminution of vision and mass in the left upper eyelid since 1 year, which was progressively increasing in nature and associated with occasional watering from the left eye and redness. There was a history of trauma with blunt object falling road traffic accident 2 years back, and there was no complaint in the right eye at the time of presentation. On examination, right eye was within normal limit, but in left eye, the visual acuity was 1/60 and not improving further. The intraocular pressure was measured by applanation tonometry, which was 16 millimeter of mercury, and extraocular movement was full free, painless in all direction. But there was a left upper lid mass on medial aspect, 1 centimeter cube, freely mobile, and bruit was heard. Corkscrew episcleral vessels were seen nasally and temporally, and rest of the anterior segment was within normal limit. Case 2 included 22-year-old male presented with sudden onset of decreased vision in the left eye, redness and pain since 1 year after having experienced head trauma. There was no complaint in the right eye. No history of any systemic illness, ocular surgery, or thyroid disorder. On examination, right eye was within normal limit, but in left eye, vision was 624, which was not improving further, and IOP was measured with applanation torometry, which came out to be 26 millimeter of mercury. Extraocular movements were full free, painless in all direction, but there was mild diffuse swelling in the left upper lid, and there is conjunctival congestion with corkscrew-shaped episcleral vessels. Rest of the anterior segment was within normal limit. Case 3 included 37-year-old female presented with chief complaint of headache and diminution of vision along with forward protrusion of the left eyeball since 1 year, which was progressively increasing in nature associated with redness of the left eye. There was no complaint in the right eye, and there was history of systemic hypertension for the last 3 years, for which she was not taking any medication regularly. There was no associated pain or history of ocular trauma, surgery, or thyroid disorder. Right eye was within normal limit on examination, but in left eye, vision was 618, which was not improving, and intraocular pressure was measured, which was 20 millimeter of mercury. Extraocular movement were full free, painless in all direction, but there was axial protrusion of 23 millimeter from the left orbital rim, which was pulsating, and bruit was heard. Corkscrew-shaped episcleral vessels were seen nasally and temporally to limbus, and rest of the anterior segment was within normal limit. All the 3 cases undergone CT angiography brain plus orbit, which was done and revealed the left-sided carotid cavernous fistula with retrobulbar congestive changes in the orbit. There was engorged, tortuous, and dilated left superior ophthalmic vein, which was seen with collateral and mass effect. Management was done under the guidance of a multidisciplinary team comprising of ophthalmologists and interventional radiologists, and the digital subduction angiography was done, which shows Davy shunting between branch of internal carotid artery and left cavernous sinus, revealing it to be indirect left carotid cavernous fistula. Embolization was done in all the cases under GA, and squid 12 was injected to obliterate the fistula. These are pre-embolization, embolization, and post-embolization images. Follow-up was done, and the patient were closely monitored in the post-operative period for any complication. On subsequent follow-up, tortuous and dilated episcleral vessels were regressed, and best-corrected visual activity was improved over 3 months. A repeat contrast-enhanced CE MRI was done at 3-month follow-up, which showed obliteration of the fistula with regression of the feeder and reduction in the caliber of superior ophthalmic vein. Many patients with carotid cavernous fistulas may initially present to an ophthalmologist who should be able to make a presumptive diagnosis. The ophthalmologist must be able to monitor the course of the disease, including extraocular changes and IOP measurement. Based on the patient's symptom, treatment may be observation or neuroradiological intervention, and spontaneous closure was unlikely, so surgical treatment has to be including ligation of the external and internal carotid arteries and fistular embolization with particles, glue, detachable balloons, and thrombogenic microcols. These cases highlight the successful diagnosis and management of indirect CCF. DSA was followed by embolization of the fistula, proved to be an effective treatment option. It highlights the importance of multidisciplinary approach in the care of patient, and long term of follow-up will continue to monitor any potential reoccurrence or complication, further adding to the body of this management. Thank you.
Do they recur after you do the embolization?
In all these 3 cases, we followed up, but there was no recurrence. But yes, there are.
What was the indication of the procedure in these patients? Because all of them
All are
have
incorrect, but there was
very mild proptosis.
There is constant on and off headache, and there was in one case there was increased intraocular pressure, which was not controlled by topical medications. And in second case, in third case, there was on and off headache. There was on and off headache in.
So all 3 of them had grade B only, because you said
Yes.
All of them had grade B.
Yes, ma'am. All of them had grade B, and in third case, the patient was continuously coming for on and off headache, and she was not taking the hypertensive medications regularly, even after repeated.
And all of them agreed for, it's a very
Yes,
expensive
ma'am.
procedure.
Yes, ma'am.
None of them you tried conservative management.
No, ma'am. We tried, ma'am, intraocular. When there was increased intraocular pressure, we tried topical, but it was not controlled, and the patient was continuously complaining of pain. And in other case, there was headache on and off, and the patient was continuously coming even after conservative management. That's why we advised for the further management.
Okay.
You could see the pulsations in all cases?
No, ma'am.
Eyeball pulsation.
Ma'am, not all cases, but there may be when there is, ma'am, the episcleral veins are very dilated, and
So how do you actually look for the pulsations?
Ma'am,
Sometimes you may miss actually.
ma'am, insinuation of the fingers, or ma'am, the auscultation bruit was heard.
From the side, you should have look from the side. Front, you may miss sometimes. If
Yes,
it is
ma'am.
very fine pulsation, you may miss actually. If you see the patient from the front side.
Thank you.
Thank you.
Can I call upon Dr. Didesh? I think on this side it's over.
Hi. Good afternoon, everyone. Today I'll be presenting a clinical study of patients with proptosis in tertiary healthcare center that was done in MY Hospital in Indore, and it under Neetu Gori ma'am. So first, as we know, proptosis is the forward protrusion of the eyeball of one of both eyeball from posterior pressure of the globe due to increased orbital volume either from intraorbital or intracranial space occupying lesion. And proptosis is graded as mild, moderate, severe, where mild is to 21 to 23 mm, moderate is 24 to 27, and severe is 28 and more. And the etiology of proptosis is variable in different areas, and treatment options are also varied. So in this study, we have shown the importance that managing physician and ophthalmologist are aware with common causes of proptosis in their area of practice in order to provide adequate treatment and also for health planning for the patients. So the aim was to clinical evaluation of the patients with proptosis, and primary objective was to study the clinical features and study the etiology of proptosis. Then secondary objective was to correlate radiological findings with clinical picture and to study the demographic pattern of patients with proptosis. Then study design. So it was a prospective observational study, and it was done in the Department of Ophthalmology, MY Hospital, Indore. And inclusion criteria was that to all the patients with proptosis who came to the ophthalmology department and are willing to give the consent. Then exclusion was patient not with not enough physical condition to perform the proptosis workup. Then methodology, 41 affected eyes of 33 patients came to the eye OPD with proptosis, of which inclusion patient was selected as per inclusion and exclusion criteria, and informed consent was taken. Then chief complaint was recorded and proper medical history was taken. Then a complete ocular examination was done, proptosis workup was done. Then clinical diagnosis was made, and based on the clinical diagnosis, blood investigation and radiological imaging test was done. As per the study, most frequent age group was more than 40 years of age. That was 27%. Then gender-wise, 19 were male and 14 were female, and male to female ratio was 1.21:1 ratio. Then axial versus non-axial. So more of axial proptosis was seen in central India. Then and more of unilateral proptosis was there. That was 25 versus 8 cases. Then based on severity, mild proptosis case was more seen. And based on the etiology, thyroid ophthalmopathy was most common, that is 9. And also a group of neoplastic conditions were also seen. So similar study was done in Kolkata and in Kerala. And in the study done in Kolkata, we can see that most common etiology is neoplasm, and age group was more than 40 years. And most common age group is male, and more of non-axial, that is 53% was seen, and unilateral was seen more, that is 82%. And in Kerala study, thyroid ophthalmopathy was seen more, and we can see that axial proptosis was more, that is 91%, and unilateral was seen, that is 51%. And comparing in our study, there is also the more common cases are thyroid ophthalmopathy and more of axial proptosis and unilateral, that is 76%. So the conclusion is that thyroid ophthalmopathy is most common in central India. Also unilateral and axial proptosis are more common, and etiology of proptosis variable in different area and needs early diagnosis, and prompt treatment is needed for saving vision of our patients. Thank you.
Was it a pure observational study?
Yes.
So what is the most important way you should have classified this? It should have been classified as unilateral, bilateral, and studied separately, because you said unilateral, most common was thyroid.
Yes,
Did all of them actually had unilateral, or the other eye also was involved?
No, ma'am. In thyroid ophthalmopathy, we can see the both bilateral proptosis.
It would have started as unilateral. Ultimately, it will become bilateral.
Yes, ma'am. But in overall, unilateral cases were more, including.
In your study, unilateral was more.
Yes, ma'am.
And in them, among them, thyroid was more.
Yes, ma'am.
Was it cross-sectional? Did you follow them up?
No, it's just
No, ma'am. Just
one-time
observational.
study. One-time study.
That's why unilateral.
Yes, ma'am.
Because
just
you can't draw conclusions like that, unilateral, the most common in your study.
Yes, ma'am. Ma'am, just the patients used to come, and I just see if there's unilateral or
Later, you
bilateral.
could have at least that subgroup of thyroid, you could have followed up and seen whether they turned out to be bilateral.
Yes, ma'am. Study design was not like that. Yes. Thank you.
Yeah. Is Dr. Ramya here? Anyone from her side knows? Is she coming? Should we call her? Is Dr. Kavita here? Dr. Kavita and Dr. Ramya are coming.
please. What is the title?
Comparative study of DC. Shall I read out? Dr. Tanima, you're going to present on comparative study of DCR with mitomycin versus DCR with intubation?
Yes, ma'am.
Okay, go ahead.
Good afternoon. I'll be talking on a comparative study of DCR with mitomycin C versus DCR with intubation. So the lacrimal drainage apparatus starts developing at the end of the 5th week as a solid cord, which canalizes completely by birth, where NLD nasolacrimal duct is the last to canalize. Any obstruction at the nasolacrimal duct at a later stages of life leads to acquired nasolacrimal duct obstruction, which presents as persistent watering and discharge. And the gold standard treatment here is the dacrocystorhinostomy. Various modifications have been involved with this conventional method, like using anastomosing flaps, suturing, rubber catheter, and silicone tube. But the failure rate with the conventional method of DCR is almost 10 to 15%. The most common causes being fibrosis, scarring, and granulation tissue formation at the site of the ostium and nasal septum. So to overcome this, in the recent stages, many adjunctive methods have been used. Most common being using the silicone tubes and antimetabolite agents like mitomycin C and 5-fluorouracil. Our study is to compare the efficacy of both these techniques. Mitomycin C, being an alkylating agent, inhibits the synthesis of collagen and proliferation of the fibroblasts, reducing the formation of scars and adhesion at the operative sites. Semasari et al. And Shulau et al. In their study have shown that the patency of the lacrimal sac syringing increased to 95 to 96% in their study with the use of mitomycin C as compared with the conventional group. The silicone tube acts by supporting the punctal position, hence enhancing the lacrimal pump function. It increases capillary action, hence increases the lacrimal drainage, and it also guides for canalicular epithelium to progress further without adhering to the surrounding tissues. So the chief objective of our study was to analyze the surgical outcome and efficacy of both the techniques, to compare the learning curve and to compare the average time consumed in both the techniques. The study was done at NRS Medical College, Kolkata. It was a 1-year observational, longitudinal and comparative study where 100 patients were included and randomized into group A with the MMC and group B with intubation. The surgery were done by the same surgeon. We included all confirmed cases of primary NLDO within 15 to 65 years of age group and excluded all congenital, traumatic, infective and malignant causes of nasolacrimal tract obstruction, any history of previous endonasal or laser DCR, any structural or nasal pathologies. The statistical analysis we did with students t-test and chi-square test. After doing all preoperative preparation, the patients underwent for conventional TCR surgery, where after creating a 15x15 osteotomy, H-shaped flaps were created in lacrimal sac and nasal mucosa, and smaller posterior flaps were excised in all cases. After this, the group A patient received mitomycin C cotton pledgets at the edges of the osteotomy site for 2 minutes, which was thereafter washed away with normal saline. And group B, we introduced 27 gauge silicone tube with mild modification in our surgical steps, and 3 knots were applied at the nasal end, and all the tubes were removed after 6 weeks interval. Post-operative follow-up was done at 1/3 and 6 months interval. The results show the chi-square value to be 0.934 and p-value to be 0.066. This is the graph showing gender-wise distribution, and here we can see in both the study groups the female population was more. This is the pie chart showing the age-wise distribution. Here we can see the 45 to 55 years age group were more involved in both the study groups. This is the graph showing the success rate in both the cases. With mitomycin C it was 92%, whereas with silicone tube intubation it was 96%. This is a graph showing the learning curve in both the cases. Here we can see with the MMC the surgeon could achieve maximum result within 2 months, whereas with the use of silicone tube it required around 6 months to achieve the same result. This is the graph showing the average time taken to complete the procedures. Here we can see with the use of MMC, the surgeon who could complete most of his cases within 30 to 40 minutes needed 60 minutes time with the use of silicone tube. The causes of failure in our cases with MMC was profuse bleeding, washing the MMC from the site of application, technical difficulties in application, or traumatizing the nasal mucosa while giving a thorough wash. And with that of silicone tube was formation of granulation 2 at the site of knots, trauma to the nasal mucosa while introducing the tube. The success rate with the conventional method is 85 to 90%, but with the use of the adjuvant like mitomycin C or silicon tube, the success rate increased to 95 to 98%. The p-value here was 0.06, which shows that there was not much, the results with the mitomycin C and silicon tube intubation were almost equal, but the learning curve with silicon tube was more prolonged and it was more cost and time effective. These were the studies which we compared with our study, and we came to the conclusion that the surgical outcome and efficacy of both the techniques were at par with each other, but the learning curve with the silicon tube intubation was prolonged and requiring more surgical expertise, and the average time taken with the silicon tube was more as compared with the MMC to give the same successful outcome. The limitation of our study was it was a small sample size restricted to age group of 15 to 65 years with a short follow-up of 6 months, and obviously it was a single institutional study. Thank you.
Yeah, I think you should have one more group in that, because without intubation and mitomycin, because even if you do a external DCR without intubation mitomycin, your success rate is 95 to 99%.
Especially primary DCR.
Yeah.
And
So
is it, all the cases in your case are done by a single surgeon? Because
Yeah, ma'am.
surgeon's factor
Yeah,
is that.
I already
Both
mentioned.
the groups by only
both the
one
groups
surgeon?
yeah, ma'am. I already mentioned it. All the surgeries in both the groups was done by the single surgeon.
Because primary DCR's intubation is not done anymore.
Yeah.
If it's a
So
large
because the
osteotomy.
success rate is good actually, 98-99% success rate we have. So you should have actually kept one more group if you want to
Yeah.
really compare.
Okay, ma'am.
Same surgeon without intubation, without MMC.
Okay, ma'am.
Then
Yeah.
you can say even those two may not be required
Sure,
in primary
ma'am.
DCRs.
Yeah, sure, ma'am. Thank you, ma'am.